Welcome back, everybody. Excited for the next part of our time together, a series of uh, presentations about how people are really thinking of the ways that academic detailing can be part of the team sportness of healthcare these days. It's you know cliches are sometimes cliches because they have a kernel of truth, and everybody talks about healthcare being a team sport, and it's kind of a cliche, but it also is true. The days of the solo clinician who could carry all the knowledge around in their head, do every piece of it themselves, that's not really how things work in the modern era, with the amount of different types of needs, different types of patients and communities, different types of services we're trying to provide, and the different types of problems we're all trying to address as people working in healthcare. So when we think about what we do as an academic detailing community that focuses on identifying the best evidence and bringing it to clinicians at the front line, we have to think about, who do we collaborate with? Who are we bridging with so that we can walk with those clinicians to better practice, to better care? And it can be a beautiful combination of any of a range of disciplines. Classically, we thought a lot about doctors and nurses and pharmacists, but it doesn't have to be limited to that sort of stereotypical classic role. You just saw some of the ideas: patient navigators, community health workers, many different types of pharmacists, not just those embedded in clinics, and on and on. And what's been really rewarding for us at NARCAD is that we've seen bubbling up from our community new kinds of collaborations, new ideas about how to put different professional roles together in ways maybe that we wouldn't have thought of, that lead to creative, different, exciting, and impactful approaches that move care in a better direction. So really excited to have these three presentations to sort of build on that theme and educate us about what they're doing, and hopefully stimulate some really good thought and discussion. So first up, I want to give a brief introduction. I'll be brief with this, and then pass the podium over to our colleagues from Metro Health in Ohio. So Christine Fishman and Amy Scheidemandel, who are going to talk to us about their work integrating navigators into AD. So to introduce the two of them, Christine Fishman, she started her healthcare career as a pharmacist, and then after she went and got her MPH, she began piloting and leading the AD program at Metro Health, especially in their Office of Opioid Safety, and she's been doing that for about 5 years. She's also working on earning her PharmD now, so continuing that pharmacist progression. And partnering with her to present today, Amy is a licensed professional counselor and licensed independent chemical dependency counselor. She's now the manager of the substance use navigation program in the emergency department at their hospital, where she supervises a team of navigators to provide treatment, resources, and support to individuals with substance use. So Chris, Amy, let me turn the virtual podium over to you to tell us about your work.
Great, thanks, Mike. So Substance Use Navigator, we are known collectively throughout the hospital as SUNS, and the SUN program was modeled after the California Bridge model, which they started in 2018 with the goal of being able to provide 24/7 substance use care in all California hospitals. And so this includes three main components of providing patient-centered rapid access to care, advocating for medication-assisted treatment, and then referring patients to those appropriate services. So our timeline at Metro, we started in January of 2024. We had one navigator, which was myself, down in the emergency department, just working 2 days a week to kind of test this out and see how it was going to work. And then around that time, we also received the Ohio Department of Health Comprehensive Care Grant to be able to expand our program and operate it full time. So in May of 2024, we had our first two full-time SUNS start working. By October, we were fully staffed with all 5 navigators. And then in November, we were able to start providing near 24/7 coverage. So we have small gaps of about a half hour. And the longest gap we have without coverage is about 2.5 hours, kind of in that 3:30 a.m. Time in the morning. But otherwise, we are available in the emergency department just about 24 hours a day. So our navigators work with patients that are identified by an algorithm that runs in the background of Epic, which is our electronic medical record system. And so you can see there is a SUD column with a little sunshine for our sons. And that is flagged based on the chief complaint they come in with, any diagnoses on the problem list, no matter how old they are, and if they have any positive toxicology or ethanol labs. So when that shows up, that tells us that that's a patient that would benefit from Sun services. Now we also, it's set up to kind of be overly sensitive and overcapture patients. So it does flag that Sun for patients with nicotine and tobacco use only, if they're on prescribed or hospital administered opioids or benzos. But our Suns have the ability to actually turn that Sun off for those patients where it may not apply to them that they have a true substance use disorder. And so being able to turn that off allows us to really focus more time with our patients that truly have a current substance use need. Okay. There is myself and my fantastic team of navigators. So what we do pretty much a whole list of things. We can refer patients to inpatient, detox, placement, residential. We have a lot of educating with medication-assisted treatment. We really try to encourage that. We distribute a variety of harm reduction supplies, including Narcan, both fentanyl and xylazine test strips, safe use kits, safe sex supplies. We can connect patients to anything they need in the community. So if they're looking for resources for food or they need help connecting to a mental health provider, basically we want to be able to help our patients. We know that substance use isn't just a singular event, that it impacts all aspects of their life. So we had a patient once that was really trying to get his driver's license back, and we printed out the whole BMV study guide for him because he didn't have access to that. So anything that we can do to help our patients to kind of encourage that sobriety or, you know, help them continue to maintain it, we will do. We can also help them with getting appointments scheduled within the hospital system. So if they aren't connected to primary care, if they have, wound needs and need to see our wound clinic, we can help them get appointments. And then we can call and give appointment reminders, schedule lift rides if needed. And then we also follow them for 6 weeks post-ED discharge via phone call. So we will call, again, some of it is for those appointment reminders. Some of it is to check in, especially if they started a medication. We want to make sure they were able to get their prescription filled. Are they having any issues? Do they have an ongoing provider who will continue to prescribe that for them, just to really eliminate any barriers that they might potentially have? Chris?
Yep, here I am. So now I'm going to, this is a much, well, it's exciting for me, but I think the work they do is extremely good work. But the academic detailing part of this whole program is that I was assigned to work with every single one of our ED providers, so physicians, APPs, and educate them on the fact that the Suns exist. We also created a discharge smart set for our provider, which included things like medications for opioids, alcohol, stimulants, and tobacco, but it also included referrals. So for opioids, we gave our providers a choice. We wanted to make it accessible for patients to walk out of our hospital with something, because studies have shown that getting medications, especially buprenorphine, can be a life-saving intervention. So as you can see here for opioids, we do Suboxone or buprenorphine / naloxone, and ondansetron, because the biggest side effect associated with withdrawal is nausea and vomiting. And then for alcohol, next slide, please. For alcohol, our patients can have access to two FDA-approved medications, one being naltrexone, which would be our first choice, with the caveat, I mean, you can see that there's a warning on the left-hand side of the screen. It's not, you know, it should not be prescribed for patients who are taking any opioids or using kratom. We have a Camprosate as another option. So the information is right there so that it's easy for our physicians and APPs to go into the Discharge Smart Set and just pick out medications. Next slide is for stimulants. And although there are no FDA-approved medications for the treatment of stimulant use disorders, we have seen there's some evidence with using medications like Wellbutrin, naltrexone, either alone or in combination. And then at the bottom, we have mirtazapine as an option. Again, with the warnings for our physicians and APPs to kind of decide if they want to use those medications or not, or if they're appropriate. Next slide. And then we have tobacco, and we decided to put that on there because you never know. Sometimes it can be helpful to aid our patients, and the medications are bupropion and then either the gum or the patch replacement therapies. Next slide.
So what our navigators have accomplished in this first year, from May of last year through May of this year, is they screened they screened exactly 12,000 patients across our 4 emergency departments. So we are based out of our main campus emergency department, and then we have 3 smaller satellite hospitals that we cover remotely via phone if a patient there is interested in getting placed in treatment. Of those 12,000 patients, we've identified just over half as having a substance use disorder. So the rest of those ones we kind of weeded out that were maybe nicotine or on prescription medication. A lot were in long-term remission, had diagnoses from 10, 15 years ago. So of those that we identified, we referred 1,762 to treatment. Now, being referred to treatment includes going to treatment, includes getting medication, assisted treatment there at the ED and a prescription to go. It includes getting just, you know, resources on outpatient programs, IOP programs. So it encompasses a lot of different services when we talk about referred to treatment. But of that 1,700, we actually placed 834 in a detox or residential program straight from our emergency department. Our risk reduction, can you go back? Our risk reduction and wraparound services, those are our harm reduction that we give out. It's also kind of the other community type resources that we link patients to. So we were able to connect and refer a little over 1,100 patients to wraparound services. And then there's some numbers on the number of Narcan kits and test strips and safe use kits that we gave out. We give out a lot of test strips. We try to really promote and encourage the use of test strips along with Narcan. And then for our follow-up that we do at the 6-week interval, we reached about 28% of those patients that we called to follow up with. Of those that we reached, though, 63% reported treatment retention. Next slide. Okay, so some of our challenges and our future plans. One of the hardest things about this job is having patients who want to go to treatment that we are not able to place in treatment. And we know that when patients are at a place where they're wanting help and they want to go, it's not a situation where we can tell them, come back in 3 days, come back when you have insurance. You know, they want to go. We have that small window of time to work with them. And so insurance is always a big issue for us, whether they are uninsured, if they have out-of-state Medicaid. Most of our treatment facilities will not even accept presumptive Medicaid if we can get that process started for them. And then especially our older population that is Medicare only without that dual coverage, it's very hard to get them placed into treatment facilities. We also struggle sometimes with different clinical and medical barriers. So even something simple as somebody being on oxygen can be a struggle to place them. If they're wheelchair bound and they need any type of assistance, they're not a completely independent transfer, that can prevent them from going somewhere. as well as the fact that our hospital system does not have its own internal detox program, and we do have to rely so heavily on those outside community providers. We also, Metro does not have a methadone program. We do have a walk-in Suboxone clinic, but we have a lot of patients who are on methadone, and most treatment facilities won't take patients on methadone either. So we do run into some barriers with those patients who want to go. Also, things like being a registered sex offender is usually another barrier for us being able to place patients. And then in terms of our engagement and follow-up, the biggest struggle is being able to reach them. We know that this population is often transient, homeless, they're staying with friends, or they're staying in shelters, and so they don't always have reliable phone numbers or access to a phone. And so being able to follow up with them is really the biggest struggle for us. Looking to the future, so we are currently funded by the Comprehensive Care Grant. That grant ends June 30th, and at this time, we do not anticipate additional funding being released for this program. So we are working to find ways to be sustainable with, being able to bill for some of our services. We're working very closely with our executive leadership at our hospital to encourage them to continue to support and fund our program, because we know that it is so needed, especially in our area and where our hospital is located, the zip code that it's located in, very high overdose rates in this area. So just sustainability and really being able to show that we, have made this difference and we need to continue to serve this population. Okay, so how to start a SUN program. These are just, I won't read through all these, but these are what California Bridge kind of recommends when you're looking to start a program like this. I will say the two biggest or most important ones probably are the providing training to providers and staff through academic detailing, and encouraging the use of non-stigmatizing language. I know that when we first started, providers had no idea who we were. They didn't know how to access us. They could not tell you what a SUN was. It was such a foreign concept to them. And within a matter of a couple months, it was SUN, SUN, SUN. They were hunting us down everywhere. So I made our staff really present and available in the ED, and really had them, go around, talk to providers, introduce themselves, remind them of what we provide. And just kind of keeping in mind that stigmatizing language that we still hear frequently, and from people that don't necessarily work with this population, just that are working in the medical field, and reminding them that it's substance use disorder. We're not calling them addicts, we're not calling them alcoholics. So that's a big part of it as well. But I think the education of providers has made this program hugely successful. You're on mute.
In academic detailing, I'm a huge fan of capturing people right when they're ready and when they're in front of me. So when I was detailing them, I had a pre-test and a post-test that contained these 4 questions. I'm aware of the SUNs in the ED. I feel comfortable prescribing medications for substance use disorders. I am familiar with available referrals within our system. And then I'm comfortable using the new Discharge Smart Set. So my meetings with them were about 20 minutes long. I met with each person individually, and we reviewed some of these things. And then I gave them a post-test. And next slide, please. And these are the results of that post-test. So as you can see, prior to the academic detailing, they were starting to hear about the substance use navigators programs, but they really weren't sure. Prescribing medications for substance use, as you can see, there's a bit of a difference there. It looks like a 40% increase in knowledge about that. I am familiar with referrals available for substance use disorders, and we even included referrals for adolescents, because that's a group of patients that is very difficult to treat. And we learned that we have a adolescent addiction medicine psychologist, and she gave us full access to her, so we could refer patients to her whenever we needed to. And then I am comfortable using the new discharge substance use disorder Discharge Smart Set. And as you can see, there's a huge difference there. So I think education for our providers about the knowledge that the substance use navigators exist, and the different tools available to them made a pretty significant impact on how they cared for patients, hopefully. So I'm not going to read all of these to you, but there's two that really stand out, and I'm going to tell you a little story. The first one is this top one, Sons Rule. This is the best new program we have had at Metro, maybe since I have been here for 21 years. I'm serious. It should be funded forever and ever. I am happy to tell anyone that needs to be told that this program is indispensable to the functioning of the ED. The other one is, I think you guys are outstanding, and the ED is 100% a better place with your help. So there's a story behind this one, and this is why it's so, for me at least, it's extremely meaningful. Years ago, when I was working, when I started working at our Office of Opioid Safety, one of the things we did is we wanted to make sure that our patients who use drugs had access to the COVID vaccine. So I went out on the RV and I was able to vaccinate people with the Johnson & Johnson vaccine. And I was taking care of a patient and he had this horrific infection. And I said, hey, the ED is literally across the street. Won't you let me take you and we'll see if you can get taken care of? And he was like, hell no, they're going to put me out like garbage. And I thought, oh, wow, that's serious. That's not good. And so if you could go to the next slide, I'm not going to read any of these, but I want you guys to see that our providers really love having the support. And every time with every meeting, I said, have you heard of the Sons? And they're always like, yes, they are amazing. So just take a read for about 2 seconds. And then I know Amy has one more slide that she wanted to share with you guys.
These are great. You should be both really proud of these. So wonderful. And these are being recorded if folks want to read them at more length later.
And I just want to share some of our positive feedback that we have had. So Molly is an inpatient son of inpatient son of ours. And she had worked with a young man in our inpatient unit, and his family had written a letter back to her saying that we really appreciate Molly's attentiveness, positivity, and ability to relate to the patient. She has done more for us through the Son program than anyone has in the 3 previous times we have been here with our son. So just kind of we really work hard to build relationships with the patients. We want the patients to see our navigators as someone that they can trust. We've had patients call, we have a shared cell phone. And like I said, we're virtually 24/7 and we've had patients call at 2 a.m. from a Burger King saying, I need treatment, I'm ready to go. And we've lifted them to treatment at 2 in the morning. So we want patients to feel comfortable reaching out to us when they are ready. Daryl, who is one of my navigators, had a patient call him out of the blue last week saying, I just want to thank you for getting me into treatment. I've been sober 45 days and I'm doing really good. So it just kind of speaks to, the impact that we're making. And Frank is another navigator of mine. He is a peer himself in recovery, took a patient to multiple AA meetings to get him introduced and in the community and to get him comfortable with going to meetings. So we also have patients that will call specifically to ask for Frank. It's just great. It just shows, I think, that the interactions our navigators have with these patients are meaningful. They're building a lot of trust with patients, like Chris said, who otherwise would not seek out our services for any type of substance use help. So it's great. I'm very proud of my team. I have fantastic staff, and we hope to continue to be able to run our program and eventually grow in the future.
Wonderful. Thank you guys so much. We have some time for Q&A now. Any questions for Chris or Amy about this really amazing integration of detailing and substance use navigation? Really just this dual approach of both supporting patients and helping clinicians learn new content and understand that there's someone specific there to provide a bridge for patients. Mike, I know you have a question.
Yeah, I have about 8, but I'll try not to hog. So I'll do one question, and then I'm sure other people will have theirs, and I can always email you guys later. It's such a cool program. I'm really curious about sort of the interaction. Like, there's clearly great feedback on the Sons, and the AD, is connecting and sort of moving the needle on knowledge attitude. Did you either did you design or just sort of by happenstance, was there overlap? Were the sons priming in any way, priming the ED clinicians to receive the AD? Or maybe were the AD sessions, getting an ED provider who maybe didn't know as much about the sons? Like, how much were they sort of two parallel efforts, and how much were they explicitly overlapping in both in how you designed it and then in how it ended up playing out?
I would say, I think, and Chris would probably know better around the time frame of when she was actually doing the detailing, but we were very proactive from the beginning, where we would reach out to every provider who was, over the patients that we had, and we had a whole little spiel that we would tell them. I'm a substance use navigator. This is what I do down here. I would love to see this patient. And so we kind of kept getting that over and over into their brain, that this is who we are. This is what we do. So that when Chris worked with them, I think it was kind of like, oh yeah, that sounds familiar. Can you, tell me more about that? I don't remember exactly what they do or how to reach out to them, but I made sure that we were super proactive. And now they come looking for us ahead of time. But that was one of the biggest feedback I think that we got, was that our navigators are so proactive. We're not sitting around waiting for providers to reach out to us. We're really there to try to make their jobs easier.
Mm.
And
Anything you want to add to that? Yeah, go right ahead.
Oh, no, I was going to say I second that, because it was really not a problem for me to schedule with every single one of those providers. I think there were 3 that I wasn't able to reach throughout the whole system. We have like 90 something providers in all of our EDs. So it was a very successful academic detailing campaign. I was able to talk to everybody, and everybody was excited about it.
So it sounds like the sons kind of greased the wheels first a little bit, and then you came in as a detailer, and that was some of the relational aspects were sort of pre-built, and you got to kind of build your own on top of that, would you say?
Yes. And it helps that our medical director is an ED physician. So that was really helpful.
Yes. Always good to have a champion.
Incredible. That is an incredible engagement percentage. I mean, for even with those connections, getting that high a proportion of the folks engaged really speaks to the to the potency of these collaborative kind of efforts, that they're not just seeing it in isolation. That's really impressive.
Thank you so much. We have time for one more question, or you can also pop them over to us via email and we'll triage them to Chris and Amy. All right. Well, thank you so much. We really value both of your perspectives on this really unique program, and definitely going to be something I know folks are going to come and ask questions about how to do in their own system. So thank you both so much.
Thank you for having us.
Yep.
Yes,
so much.
our pleasure. All right. We're going to transition to looking at a different kind of synergy, academic detailing and community health workers. So let's just take a quick moment and throw a chat waterfall out there. Thinking about community health workers, what's a word or phrase you'd use to kind of describe the essence of CHWs or their importance? When you think about them, what's the first word that comes to mind? To me, I kind of think of them as the glue. Elizabeth says culture. Mike says patient-centered, heroes, champions, connectors, underutilized, housing, empowering communities, vital, patient advocates, a bridge. Another one for vital, another for essential, unique insight and understanding. These are all beautiful and very much a snapshot of why CHWs are so valued. And I'm excited to pass it back to Mike to introduce our next presenter.
Yeah, so this is, again, building on the theme we talked about of these collaborations across disciplines, and the way that by pulling together we can figure out how to have a broader impact. So this presentation from Yahara Valdez, she's a public health specialist who works with the Oklahoma State Department of Health. Her focus is on programs to improve diabetes and cardiovascular health across the state. She works with the University of Oklahoma College of Pharmacy, supporting efforts to advance health equity. She's also a certified medical interpreter, so she's particularly focused on serving the Hispanic community in Oklahoma, as well as being a diabetes lifestyle coach, a mental health first aid responder, wears a variety of hats. But what she's here to talk to us today about is community health worker training beyond the clinic walls, another chance for us to think about these interdisciplinary and multidisciplinary approaches. Yahara, excited to hear from you.
Thank you, Mike. Hello, everybody, and thank you for joining us today at our community health worker presentation. I will give a disclaimer before I begin. My throat's been a little off within the last couple of weeks, so it might be a little scratchy here and there. But today we'll be presenting on the topic of community health workers, or also known as CHWs, as I may refer to them throughout the presentation. Next slide. All right, so our disclosure disclaimer notice, we do want to state that our only funding has been provided from the Oklahoma State Department of Health. As you can see here, we have no conflicts of interest. Thank you. So we will start off by talking about why community health workers, or CHWs, matter in the state of Oklahoma. As you can see here, we have a map to the right of the screen with the medically underserved areas and populations in Oklahoma as of March of 2023. We can see the majority of the map is light blue, which the light blue color shows us the medically underserved areas, which is majority of the state. And then we have a small tiny portion of light green that shows us a governor's exemption, which refers to the areas that did not meet the strict federal criteria quite yet, but it did, for medical purposes, they were granted MUA status through a special request made by the governor. So MUA, as you see on the map, or medically underserved areas, are an entire area where everyone is living with the overall shortage of healthcare. So while MUP is medically underserved populations, they are a specific group within the area. The one specific thing that caught my attention the most on this map, I think maybe all of us as well, is that the majority of the state is blue, meaning that the majority of the state is medically being underserved. So out of the 77 counties we have here in Oklahoma, only 7 of them are not fully medically underserved. So that tells us only about 11% of the state is not being underserved, and probably borderline closely to being underserved as well. So this information then helped us understand the importance of a community health worker. Due to the high current disease of burden in our state, we were able to find large gaps in Oklahoma. So a lot of these gaps, the majority of them are being underserved because we are very rural in Oklahoma. When you think of probably Oklahoma, you may think, maybe cowboys, countries, horses. To some extent, it may be like that. We are very rural and we're a lot of land, a lot of greenery. So that includes a lot of burden, a lot of people that won't have access to going to a clinic, a lot of minority populations. So this information helped us conclude that a community health worker was essential. It would be the best person to help us in these areas. They are, ideally, the trusted bridge from a community to any kind of care or resources. So because a community health worker was most of the time, they are citizens living within these communities, they're more likely to be trusted than a provider or a healthcare employee or anybody else coming from outside of the community within. Next slide. So I'll start with talking about kind of where we started and our baseline information we had to begin with. We had a baseline of 0 or close to 0 on most topics that pertain to CHW work. We had literally no statewide certification for community health workers. As expected, the funding was also extremely limited and close to nothing. The resources that we had available were very scattered and uneasy to find. And there weren't very many CHWs throughout the state. I believe there was only like 32 for the whole state of Oklahoma, and they were very burned out and extremely maxed out on a lot of work on their plate. So then unfortunately for those that wanted to take any kind of trainings to help relieve the burden in community health work, the trainings were very expensive. They were not affordable and they were not even easy to find at some point. Next slide. So the process that we used to create the training was made out of mostly free tools. We began by planning out the content. First, we did our research on the core qualities of a community health worker, and then we based off the information for the key concepts to be the ideal community health worker. Within these concepts, we were able to narrow down the topics that we saw that would help and benefit Oklahoma the most. The material that we pinpointed included SDOH, or also known as social determinants of health, which we will go more into depth later, and then the Prepare Screening Survey, which is the learning of communication between communities and providers to CHWs. So we began our research and design. We did all of our research through trusted websites like the CDC, the WHO website, and the NACHW. So off of our research, we then began creating rough drafts, slides, handouts, infographics, anything that we could use to start this organization. And we did it all through the free version of Canva. We later used the paid version, which is, I believe, $12.99 a month, but the free version works just as well. We were able to do everything nearly the same with the free version. So then we wrote and formatted the material. The material was mainly created using Microsoft Word, Google Sites, Google Docs, and those are all free as well. So we were able to save those documents online and be able to share them with different collaborators in the creation process and share the documents, make any edits and things of that sort. So to conclude the creation portion of everything, we started sharing the material with others. We built the actual training modules on the free Canvas, which is a program used with universities, but a platform to use for programs and learning courses, and a lot of universities may use it for school courses as well. This program was very easy to navigate, and it even includes a tutorial on how to use the system step by step. Again, this was free, and it was able to work nearly as well as the paid version of it, which is what we chose to go with the free version. We then began sharing our material to our community partners and continue to share it on all of our monthly meetings. We have continued to advocate for it and tried to always include it in our conversations to our new partners. So within these same lines, we also created a free community health worker hub, which was used using Google Sites, which was free. And then we gathered all the resources we could find on all of the sites in our state and formatted them into this Google Site website so that anybody could use it. It includes forms, how to sign up for Medicaid, how to enroll if you're uninsured, along with pages of how to do things. Maybe if you're looking for a job, anything like that. All kinds of resources are on this hub. This page. So now that we kind of went through the process of what it took us to create the training step by step, I'll take you a little bit more about the actual building of the program itself. So to the left here, we see the screen where you can see a screenshot of the main page of our training. It includes a welcome portion with what the training information has, and then information on myself, my contact information, and the beginning of our training. So in order to get started, we had to jump through a few hoops, a lot of barriers, and a couple of times we had to obtain the best outcomes for our training. So due to the lack of resources and information for community health workers in our state, a lot of the baseline zeros, as you saw earlier, it was a lot more difficult to try to figure out where to start, where to begin, who to talk to, who to reach out to. So we began with an area that we thought was more prominent, like meeting with the state and having them review our training. Then we met with community health workers coordinator at the state level, who then shared our training with their community health workers that were able to go over our training and make sure we were up to standard per se and aligned with the community health workers within the state qualifications that they were wanting to meet. So we covered all areas like social determinants of health, which I spoke about earlier. And those are the conditions in which people's lives, the conditions that people live. So like where they live, where they work, how they learn, how they play, everything that may put an effect into their health and their well-being. So we also put an emphasis on the Prepare Screening tool, which is a survey that is used to help health workers ask questions about a person's life, like housing, food, money, stress, any questions that you don't want to ask directly in a non-direct manner, but you're still able to understand their needs if you were to give them the survey and connect them with help. So we also covered communication and referrals and how to go about that once we have the information from the patients. So besides a few topics, we still did a little bit deeper and went a little bit more personal into the aspect of learning about stigma, teaching community health workers how to read body language, the importance of culturalism, how to talk to a person one-on-one, not just going off of a worksheet or not just doing a survey, but truly having a conversation with them. While we do prefer a community health worker to work within the community, there may be times where they're going to be working outside of their communities. So it was important for us to help them be able to understand and confront different cultures, learned how to use culturalism and kind of read the room and read the body language. This is where we decided that it's important to bring the culturalism, the stigma, the reading of body language to support those in need and make them feel comfortable around our community health workers. I think overall it's very important for a community health worker to be trusted overall, for the patients to trust them and be able to actually share with them what their needs are. So we created the training thinking about all people. It is adaptable for clinics, churches, libraries, everybody with or without medical expertise or background, although we did put a little bit of emphasis on churches and libraries and community centers. Screen. So in the process of the creation of the actual training, we decided to take CHW training beyond the clinical walls. We thought about the traditional training that everybody goes through, the modules, but how often do they focus on only clinics? So what about those outside of the clinics? What about everybody else? We were inspired by a project that placed blood pressure cuffs in barbershops. So they started to meet people where they were already being gathered instead of having the patients go to the clinics, which a lot of the times they probably won't. They may not have insurance, they may not have a way to get there, they may be afraid for one reason or another. So in the state of Oklahoma, like I mentioned earlier, in every county, we have only 3 things: a library, a church, and a pharmacy. So that really inspired us to try to hit those areas as much as we could with the shortest proximity available to everybody in the state, probably a lot closer than a clinic. The pharmacy piece is being handled by another partner, so that we can cover all 3 portions of locations that each county has to offer. In order to decide where we wanted to start first, we had to identify those with the largest need. In the state of Oklahoma, very rural, and we often don't even have clinics, hospitals, or urgent cares anywhere nearby. So we do have one thing in this area, which is a trusted community space. We then saw the importance there is for everybody to learn more and increase their knowledge in or out of the healthcare space, which would inspire us to go beyond the clinical walls. So working outside of the traditional clinics helped us fill in a lot of gaps. Those that may not trust the healthcare system for one reason or another, may not be able to access a healthcare facility due to insurance or literally transportation issues, financial burdens, or many other barriers that may get in the way. So we made it our goal to bring the training to these spaces rather than expecting the patients to come to the community. Next page. As mentioned earlier, we included the Prepare Screening tool, which is what you see here on the screen. It is one of our main components of our training to better understand and help the patients in their needs. The Prepare Screening tool is a validated screening tool that was created by the National Association of Community Health Centers, and it helps health workers identify social needs like housing, food, transportation needs, and anything that may affect a person's health. Yes. So the great thing about the screening tool is that it is provided in 25 plus languages, so that we're able to help even more communities. It even includes a Native American version, which was extremely touching, specifically here in Oklahoma, considering this is a group of people that are often forgotten or unseen. So as a native bilingual speaker myself, I've seen firsthand the importance it is to have any document translated into our native language, and the increase in trust we increase or feel when you feel truly heard and seen and cared for. While this may be such a simple detail, to those non-English speaking communities, it may mean the world to them. Next slide. Some barriers that we face along the way included the lack of pathways for certification. So we created our own pathway. And then, as mentioned earlier, the trainings available were very expensive. We also discovered that a community health worker has very limited access to data due to not being able to access patient information. Most of the times, if you're working outside of a clinical area, you will not have access to EMR systems. So retrieving any kind of data or have analytics to get a better understanding of the community was very difficult. The lack of resources was also a really big one we noticed, where there was no centralized hub or location or spot or meeting for an organization to come together and work as a community, as community health workers as a whole. So as a public health professional, this one really opened up my eyes. The lack of consistency in our state and the need for our support to help create a safe space for community health workers to share their ideas, different things going on in the state, different issues, pandemics, whatever it may be going on. So while funding gaps were also a large barrier, we saw it more as a challenge to be able to work around it and do the best that we could with the free resources that we had to create the training from scratch, the best material available. Next slide. So we had to come up with our own solutions with the barriers we faced. Due to the barrier of nurse certification, we found a solution to the creation of our own certification that was vetted by the state, which allowed a free community health worker to go live. Since there are limited to no resources available out there, we created our own resource hub for the community health workers to help them with many different tools. Due to the limited funding, we partnered with multiple organizations like the AHA or the American Heart Association, which is a national organization that works to keep hearts healthy and prevent heart disease through research, education, and community programs. And we also partner with the UMC, which is the United Methodist Church, that is a Christian church that supports community programs to help people with health education as well and social needs. There were many others where we were able to gather different resources and blood pressure cuffs at one point through the American Heart Association, where they lended us free blood pressure cuffs, handouts, and trainings and tools. Many different resources were gifted to us. And as mentioned earlier, we had one of the main barriers, the funding gaps, which is why we decided to create this training from scratch ourselves to be able to offer it for free for everybody else. Next slide. So now you've seen our training and why we did it, how we did it, the step, the process, everything that we did, what it all entails. But maybe you're asking yourselves, where does the academic detailing come into play? We brought in academic detailing to inspire our actions and truly help us motivate providers, the library directors, the pastors, and all those in charge of taking part of our training. We showed them all of our facts, our research, and overall experiences with working in this field, and explained to them the spaces that are often overlooked but deeply trusted by the public and the areas that we could do the most work in. We included as part of our academic detailing the facts, the training being free. This could be a big factor to many. The fact that it was made for anyone and everyone to take it, with or without healthcare background, and then the use of even your personal experience and knowledge. Not only does this training help you understand or find the gaps in the healthcare field, but it shows us how to talk to your community, how to make a difference, how to approach a person. If they may seem down and they may need help, they're screaming on the inside, but they don't know how to put it into words or how to ask for help. So helping reading the body language was a big one. And being able to share our resources with them when they don't know how to approach us. We took this training and we put so much passion and time into it and converted it into a true change in our community with the use of academic detail and helping us show everybody the importance it did along the way. So it wasn't easy, but I think more than anything, what helped us along the way was to not create a sales pitch, but have a conversation with the providers, the library leaders, the church ministries, having actual conversations with them, getting our message across in a simple and easy way. We try to put into words our feelings and actions that we have and taking these large strides, having, the large burdens around the whole world right now, but specifically in our state, being able to offer the training for free, but also having it flexible. We offer it to either be virtual, in person, or self-paced. And then the overall, we added an emphasis that we're trying to work towards the same goal everybody else is in the healthcare space. And that is having a healthier world and having everybody have access to healthcare and resources. Next page. So now a little bit about the resource hub we have been mentioning. To the left here, you see a snapshot or a screenshot of our community health worker resource hub. It includes different tabs like resources. You're able to find a large number of resources on here with not just the link, the phone number, the addresses, forms, and everything is for free. It even includes continued education trainings, different data collection forms, anything that a community health worker may need to get up and running and started. Next page. So now you're probably wondering, what impacts have you guys done so far? So the impacts we've done has begun to take this. Everything took off in the beginning of this year, so we're fairly new, but we have already trained nearly 20 community health workers. We have multiple partnerships that includes different libraries like the Oklahoma City Metro Library System, the Pioneer Library System, the programs that help the state, like Double Up Oklahoma. So they're currently working on spreading resources and vouchers for food. So we have shared multiple different resources and tools statewide, and have been able to see an increase on the traffic on our platforms daily. So lastly, the impact we've made with working within churches. So with the UMC Church, we have added an additional 300 plus churches that have opted in to receive our regional training this fall. And then besides all of the work that you see on this page, we also have different partnerships going on behind the scenes and working to start in the fall of 2025 as well, like working with our American Heart Associations and different trainings going on. So while this started as a simple, silly idea of creating a community health worker training, we have now engaged in the community from start to finish and grown to be something beyond our expectations. Slide. So you may ask, what's next for us? What's next? We want to continue to include more people, to increase the number of trainings. We want to have more partnerships. We want to continue to increase community health workers and ideally help them take the next step, help them become Healthy Heart ambassadors, help them be in every church and every library. Somewhere, we want to have somebody in every location that's aware of the resources out there available to everybody. Along the same lines, we want to make our resource hub multilingual or make it specific to each rural area, community, or even the zip code to help them more personalized information. And then we also want to share our work we're doing currently in REDCap. So it's a secure HIPAA platform. And so we're beginning the works to use this as a platform to eventually have a QR code and be able to access more people out there in an easier way, to have them take our survey online, and then they will be able to share their resources with us via text or email. And last slide. So this concludes our community health worker presentation. I want to thank everybody for being here and for the amazing NARCAT team for taking us in for our presentation.
Thank you, Yahaira. That's wonderful, and such synergy with the Metro Health presentation as well. This idea that academic detailing can really be looking at the communications approach to get the right kind of evidence-based training and communications approaches in the hands of not just clinicians, but also in the larger community. And the idea that, it seemed like there was a massive bridge here that needed a gap that needed to be bridged rather. And that where there's a will, there's a way. So I loved the focus on free resources and the ways in which you can build things with blocks that are out in the world and start piecing them together. So very impressive. And we have a comment in the chat. Thank you for sharing, and what a huge reach you've accomplished at the community level. Any other responses to Yahaira's presentation, questions, thoughts, or reflections?
I did see a comment that said, I'm curious if one area was more responsive for the training. Honestly, once we showed them all of our information, all of the data, all it entailed, everyone has been pretty responsive, but I will say those rural communities, I put an emphasis on them because they don't have a lot of things out there. They don't have a lot of access to many things, honestly. So whenever we introduced this idea, they were really interested in bringing something into the middle of nothing. So definitely the rural communities were the more responsive ones.
And I think it's really important that, thank you for catching that. I missed that question. That you identified that every community had a library, a pharmacy, and a church. So working with the places that people already gather. And that's a really beautiful segue into our final presentation for the day, where there's going to be a focus on the trusted relationships that pharmacists can build with patients in the community. So thank you again, Yahaira. We really appreciate you. Thank you for your thoughtful presentation. All right, here's one of our last chats for the day. Vishal, over to you.
Yeah, so we're gonna go ahead and round it off with another chat waterfall. So here we're talking pharmacy. So tell us in a word or a phrase of your choice, why pharmacists are of such high value within our communities. Let's hear what some of our answers are. So we got pharmacists are accessible. Yes, absolutely, Christine. Heather says accessibility. Yep, seeing some great commonalities there. Regular relationships, absolutely, Bevan. Dominic says they're trusted. Yes, they are. High level of trust, some agreement there. Some connection to community, absolutely. We got some strong communication skills, subject matter experts, absolutely. And Narissa says, even though not biased, they are awesome. I would have to agree. They are pretty darn awesome. Following long term and seeing prescriptions from all providers, absolutely. Very needed, more needed.
Yeah,
Last
we
line of
need more
defense.
pharmacists. Yep.
Yeah, I totally
We really
agree.
What were you going to say?
Absolutely.
Last one. Yep.
Last one was just rounding out the last line of defense, especially for OUD. We got, some sometimes accessibility, trust from the community. All great thoughts and all very, very accurate. Can ask them for resources, not just medication pickup. That's so true. Absolutely.
And I remember reading a statistic recently that people live in closer proximity to, I'm probably going to get this wrong, but something to the degree of people live in closer proximity to their pharmacist and see their pharmacist 4 times more often than they see their primary care clinicians. So something to think about as we prepare to introduce Derek LaRue, a pharmacist himself and the director at One Tennessee. Mike, over to you to kick off our final presentation of the day.
Yes, and I will be quick on this because we really do want to hear from Derek. But we're big fans of the One Tennessee program. We went out and interacted with them, I think, around when they were getting started, which feels like just the other day, but was before the pandemic. So it must have been 6 or 7 years ago. In any event, our presenter today is Derek LaRue. He's the Director of Academic Detailing Services for One Tennessee. He oversees program operations, training, content development, and outreach. He's got decades of experience in clinical pharmacy practice. He's done just about every role you can fill as a pharmacist, and has a range of advanced training and certifications, such as in buprenorphine initiation, diabetes care, medication therapy management, and many others. So perfectly positioned to talk to us about how AD can empower pharmacists. Derek, over to you.
Awesome. Can you guys hear me?
We sure can.
Awesome. Thank you so much. So again, my name is Derek LaRue. I'm the Director of Academic Detailing Services with One Tennessee. And today our focus is going to be on empowering pharmacists through academic detailing. So before I get into the disclosure and everything else, I want to start off with a quick story about why this is so important. So not too long ago, a mother walked into her local independent pharmacy. Pharmacy wasn't new to her. Her and her family had been going there for decades. Even whenever her son was born, first place they went to after leaving the hospital. The day that she showed up for the pharmacy, she wasn't there for a prescription, wasn't there for a refill, MTM services, immunizations, over-the-counter items. She was there because she was there out of fear and desperation. She told the pharmacist, who she's known for decades, that she had a problem. Her son was in dire straits, and they were ashamed and they were desperate. They didn't know where to turn. So she asked him, "What do I do? How can you help me?" So the pharmacist, being problem solver, friend of the family, comfort the mother, tried to provide, access to naloxone, said they'd be more than willing to call the primary care physician to see if they can help. And she kept reiterating, "We need to get him help today. Where do I take him? What help is out there? What do I do?" At that point, the pharmacist hesitated. Now, luckily, this individual in this area had already been detailed by One Tennessee multiple times. That pharmacist reached out to me. I was in the middle of a shift working at another pharmacy, and I was able to put them in contact with a local recovery center. So because of that detailing that happened, that trusted relationship that was built, we were able to connect them to a partner that was able to get that young man into a recovery clinic, and he is now engaged in care and is on his recovery journey. So that's what this presentation is about. It's the real impact of academic detailing and what we can do as academic detailers to give pharmacists tools to help them out. So with this, before I go on, any disclosures, like I said earlier, I'm an employee of One Tennessee. I'm also a staff pharmacist with Walmart Pharmacy and a staff pharmacist for Cedar RX, which is a closed door pharmacy inside Cedar Recovery, which is a recovery clinic. I have no relevant financial relationships or conflicts of interest to disclose, and the presentation is intended solely for educational purposes. It does not promote any commercial products or services. Slide, please. So hopefully today, at the end of this, you'll be able to describe the role of a pharmacist and what that role is in harm reduction and how we as academic detailers can support them through real practice change. You'll be able to compare how we approach detailing differently in pharmacies versus primary care clinics or pharmacists in an ambulatory care setting. And then also how to normalize harm reduction through relationships, not lectures. I'm also going to share One Tennessee's local distributed detailing model and how we use that to empower pharmacists and other healthcare providers. And then lastly, we're going to examine some practical strategies to enhance harm reduction. Slide, please. So before we dive into this, what is harm reduction? If you guys can, hop over into the chat, and if you could list what you think harm reduction is, both from a clinical standpoint and then also from an everyday life standpoint. I just like to see what examples we have.
Would you like me to jump in, Derek, and read some of these?
If you don't mind.
That'd be helpful. Sure, sure. So we have acceptance of a human being, harm reduction is life, one more day, meeting folks where they're at, lives saved, keeping people safe, empowering, and another one for saving lives. It's meant really changing my beliefs as a prescriber, engaging patients without judgment, meeting needs. Yeah, all great stuff.
Awesome. Excellent. So what I like to do, and all of those are exactly spot on. So whenever I'm going in and having a conversation, what we like to do for is normalizing harm reduction strategies and removing that stigma from it. Because 9 times out of 10, the moment you mention harm reduction, at least in our area, the first thing that comes to mind is safe syringe programs, and which is still a very stigmatized program out there. So what we like to do is talk about seat belts, sunscreen, water, vitamin C, immunizations, vaccinations, safe medication disposal, naloxone, access to care. All of those are harm reduction strategies that are easily implemented or that we already do. They ultimately reduce risk. And like you said, they save lives. And I think the most important point out of that chat response was we meet people where they're at. And that's why pharmacies are important. Slide, please. So now that we have a solid grasp on what harm reduction is, let's take it one step further. Pharmacists, we already do harm reduction every day. We may not call it that, but I think it's important to understand that we do. And that's going to be one of the building blocks that we can use when detailing pharmacists to give them the confidence to continue to help their patients and their community. So things, like I said, counseling on safe medication storage, administration, offering naloxone. The big one for me is contacting a prescriber when there's a DUR conflict or a drug-drug interaction, as particularly with opioids and benzodiazepines, or simply counseling the patient or calling them back after meeting with them about an antibiotic, starting insulin, new blood pressure medication, something like that. So with academic detailing, it ultimately helps pharmacists understand how these actions fit into a broader harm reduction model, and then enables them to take the next step with confidence. Slide, please. And you guys kind of already answered this one earlier. Why community pharmacists matter. So for me, like Evan said, pharmacists, we see our patients more frequently than most prescribers and other healthcare professionals. And I think that's extremely important. And it's not because they're coming to us every time for their needs. They're coming to us to pick up for their family, picking up for someone they're taking care of. And examples like that. And that's the reason why counseling is so important, to counsel those folks on access to naloxone. Because again, if they're picking up a prescription for an opioid, it may not be for them. So another reason why in both rural and urban settings, pharmacists are trusted, familiar, and accessible. In many communities, especially rural ones, that they have regular access to or interaction. These day-to-day interactions make pharmacists extremely positioned to notice changes, have conversations with patients, and then offer practical support in a trusted setting. So pharmacists aren't just passive recipients of academic detailing. They're key players in harm reduction. When a fellow pharmacist shares a resource or suggests a workflow shift, it carries credibility. That's why peer-to-peer detailing is so effective. At One Tennessee, we recognize this. When we offer our training program, which is about 12 to 20 hours total when a new detailer is hired, we work to train them to empower pharmacists, but also to empower themselves to be able to have the tools to go into these different communities, these different settings, to be extremely effective. So these pharmacist detailers not only deliver messages that land, they also understand the real barriers that come with a community pharmacy setting. So One Tennessee, we don't just focus on what needs to be said or what gets said. We focus on who's saying it and how well they understand the setting that they're walking into. Our academic detailing team not only includes pharmacists, but more importantly, it includes nurses, nurse practitioners, physicians. So therefore, we have a wide range of healthcare professionals that allow all of us to learn from everybody on how to handle each setting that we go into. And so with that, before a detailer gets into going into a pharmacy, we'd like for them to go detail with either myself or one of our senior detailers so that we can show them the ropes, kind of go over what the workflow is in the pharmacy, what to expect, that kind of thing. So in a pharmacy setting, our messages must be concise, clear, non-judgmental, and directly tied to patient safety and outcomes. An example that I like to use when we're training is instead of saying you should offer naloxone, number one, that's going to allow folks to immediately put up walls and shut down. We don't want that. Again, think active listening, motivational interviewing. So instead, ask many of the pharmacies in our area are keeping naloxone. What is y'all's policy and procedures for offering naloxone to patients? Just a simple rewording makes a huge difference. We aim to reinforce shared values such as safety, prevention, and community care. And we do this by conveying these messages in a manner that respects time, space, and also the workflow in a pharmacy. Slide, please. So whether you're detailing a pharmacist in a community pharmacy, a pharmacist in ambulatory care setting, or a provider in a clinic, the end goal is ultimately the same. We want to provide evidence-based guidelines, unbiased. We want to be able to have a conversation. I've heard that several times this afternoon where we don't want to come in and provide a lecture to the folks that we're detailing. We need to be having a conversation. So again, the only thing that I will say with that is just remember that every environment you're going into, especially a community pharmacy, is going to be different. So in clinics, you're able to typically schedule an appointment. There's going to be a team-based environment. You have time to do a deeper dive, typically 30 minutes to an hour in those detailing sessions. However, in a community pharmacy, the pace, of course, is much faster. There's limited privacy and there's typically no support staff. So that means that we have to change our approach. So with our materials, our tone, our approach, everything must shift. Our messaging needs to be faster, leaner, and designed for more one-on-one conversations, even reducing the amount of topics that we cover. I know that during my NARCAD training, we always talked about keeping it less than 3 topics. We usually tell folks going into pharmacies to keep it 1 to 2. And if it expands, that's great. And if it doesn't, just keep it to 1 to 2. That way the point is taken and then it sets you up for follow-ups. Slide, please. So when we talk about harm reduction, especially in close-knit communities like rural areas, we're not just talking about health, we're talking about the culture. We've heard that a couple of times this afternoon as well. So remember, in these communities, especially in small rural towns, everyone knows everyone. That means that stigma is an extremely real barrier and it needs to be overcome. However, I'm going to go ahead and say that close-knit community can also be a strength. The closeness between the individuals in the community and the providers that are serving them can end up being a strength and promote improved patient outcomes. So also remember that pharmacists are often more than providers. We've heard this in the chat. They're your neighbors, they're your friends, they're trusted figures. When we help them frame harm reduction as protecting their community, saving lives in their community, and doing no harm to their patients, we're going to meet them where they're at and ultimately build trust. Slide, please. Now, whenever we start our detailing training, I tell the detailers that are being hired on that you're going to hear me say multiple times several words: evidence-based medicine, evidence-based care, unbiased, professionalism, respect, and the one that I always end with is trust. And I think it's mainly because trust is everything. And with that, it doesn't happen overnight. That's the reason why, as detailers, our job is not to show up and act like we have all the answers. It's about listening. It's about understanding the setting, the patients that they're taking care of, and then ultimately offering the support without any pressure to make a change until they're comfortable with doing that. Think we're not regulators, we're collaborators. When a pharmacist sees that and they feel like that they have an approach and they have a partner, then that trust opens the door for us to come in and help them provide the tools. It's extremely important in our local distributed model that we use at One Tennessee, where we have local detailers serving local pharmacies. We just heard that a minute ago with the healthcare workers, which I think is outstanding. Having that trust forms faster, and it allows deeper relationships to form because you're aware of the community that you live in. Slide, please. So a little bit about One Tennessee's local distributed model. Our academic detailers live and work in the regions they serve. Ideally, especially like in Nashville, Tennessee, we have one detailer that covers the entire metro Nashville area. We're trying to hire more for that area. I'm in a lower part of Middle Tennessee where I cover 5 to 6 counties. Now, I've detailed all, well, I don't want to say all 95, but I've covered all sections between East Tennessee, West Tennessee, and Middle Tennessee. But ideally, our goal is to get someone that's embedded in that community or in that health system. That way they have direct access to those folks and they understand what needs to be taught, the barriers that need to be torn down, and the tools that will ultimately, again, provide the best patient outcomes. So this is different from a centralized approach where the detailers might detail in unfamiliar communities. They may be in a call center or they're doing everything virtually. Again, those models work well. I think for a rural setting, having someone there that they can trust is extremely important. So ultimately, our model allows for ongoing relationships, regional credibility, and local relevant approaches. One thing that I push all of our detailers to do is become active in our community, from joining local drug prevention coalitions, local drug pharmacy societies, healthcare professional societies. Become a member of that. That way, not only can you get access to other individuals, but you now have a seat at the table when discussing issues that are affecting your population. So remember, we're not just delivering messages, we're building connections. And that's what makes change possible on a local level. So next slide, please. Pharmacists are already educators, we're advocates, and ultimately one thing that I always hear some of my colleagues say is we're problem solvers. Academic detailing amplifies that role for pharmacists. The empowerment doesn't mean giving someone a to-do list. You know, that's very important for everybody to remember when you're detailing, you're having that quick conversation. You don't want to hand them a to-do list. You don't want to be a regulator or a moderator. You want to give them options, tools, confidence in order to help their patients. So when a pharmacist decides to keep naloxone in stock, to talk to a patient, to refer somebody to counseling or to treatment, that's harm reduction in action. And that's what we're trying to accomplish. So remember that every little step along the way, think about going back to your original academic detailing training. You may not make a huge push that first session. Your follow-up visit may be the one that happens, or even the third one. But every little slight shift makes a big difference. And ultimately, that's what we're going to have to do to be effective. So real quick, because I know we're running out of time. Key takeaways. Harm reduction is already happening every day in pharmacies. Build on that. Normalize it. Encourage the pharmacist. Educate them that they're already doing that. That way they get comfortable with starting to do other harm reduction strategies that may be a little stigmatized. Pharmacies are a pivotal access point. We've touched on that before we started this session and then during the chat. Respect the pace and the culture that's in that pharmacy. Learn to be flexible when you're doing your detailing session. Be able to pivot. If there's only one pharmacist working and they're having to go counsel, they're having to go give a couple shots during flu season, be aware that your time may take a little longer. Be willing to ask, can I come back at a later time that would be better for them? Again, academic detailers, we want to build bridges, not mandates. We want to have a local perspective and then order by having that, we're going to drive success through trusted relationships. And then last but not least, pharmacists are not just the audience, they're agents of change. So if you go in and you detail a pharmacist, you go in and meet some of these folks, ask them to join your program. Ask them, is there anybody that they need to go talk to? One thing that I always say is, with the small towns, we talked about trusted relationships. Everybody knows everybody. I don't want to jeopardize that pharmacist or that provider from damaging a relationship because there's a need for me to go detail somebody. So I always tell folks, my mandate in the state of Tennessee is I need to go talk to anybody that can either prescribe or dispense opioids. So therefore, if there's a practitioner in that area, I want to go talk to them. If you have an issue with somebody who's prescribing benzodiazepines, Zolpidem with opioids, contact me. Let me go talk to them, provide the education to help. So ultimately, we take care of your patients. So with that, thank you guys so much for your time and attention. And more importantly, thank you all for the work that you do every day. I'll turn this back over to Bevan and answer any questions that you guys may have.
Thank you so much, Derek. That was incredibly inspiring and a great way to put the spotlight on pharmacists. There are so many pharmacists in the audience right now that I know work really hard and often don't get the recognition that they deserve. So big ups to all of them. And we have some space for any questions for Derek, if you'd like to pop them in the chat box as we wrap up the day. I'm going to run through what you can expect tomorrow. And then if any questions come in for Derek, he will be able to answer those. Tomorrow, we have a really quick overview of the agenda. We'll kick off at 12 and we'll go right into program development workshops. We'll take a half-hour break like we did today. We'll have a quick plenary for an hour and a quarter about the evolution of AD and new applications. Another 15-minute break, and then we'll end the day with stories from the field where we see AD in unique implementation settings. Going to include things like resorts and casinos, long-term care facilities, you name it. So please be joining us tomorrow for some really exciting final presentations for the week. Meanwhile, Vishal just popped our evaluation form in the chat. If you have the time and energy to fill that out, we would be grateful as detailers and public health incredibles. We know you know the value of a survey, and we'd like to know what we could do better next year. Mike is also proposing a site visit to a resort or casino, and I will say that we have done that before. We did a detailing training in Las Vegas, where every morning we had to walk through a casino full of cigarette smoke and a lot of older adults ashing their cigarettes into whiskey. So NARCAD remains exciting, and so are all of you. Thank you for keeping us on the edge of what is happening out there and for making space for each other. Please do take a look at our evaluations. And if you'd like to stick around and chat with Derek or any of the other incredible presenters that are still on, please do. But otherwise, we will see you tomorrow. Thank you
Thanks
so
so much
much.
for being here.
See you tomorrow, everyone. That was fantastic.
Appreciate you. Thank you very much.
Derek, do you guys connect with like the practices mostly, or you sort of, your priority is talking to the pharmacists? And I'm curious whether there's other folks detailing the prescribers, just because it would be so complementary.
Yes, sir. So whenever we first started, well, let me back up. Whenever I came on board, pharmacists weren't included in the equation. It was all about detailing prescribers. And initially it started with focusing on opioid prescribing, more so than opioid use disorder, trying to get ERs, chronic pain management guidelines to be put in place. And then whenever I was hired on, we had a discussion about where to shift and how to look at strategic planning. And I mean, my big thing is I've been in pharmacy for almost 23 years. And like I said, I mean, we're that last line of defense. And so I feel like we're doing a disservice to the profession that all of us were in as academic detailers and pharmacists at the same time to not include pharmacists. But to answer your question, we detail pretty much anybody in the state of Tennessee that's either going to write or dispense an opioid, or has to do with opioid use disorder or substance use disorder.
Gotcha. Okay. Yeah, no, great I mean, it's a while ago now that we came out to you guys. It's really exciting to see.
2017.
that
Yep.
stuff. Was it really
Yep.
2017?
Mhm.
Holy
Yeah.
smokes. I
Yeah.
would have guessed it was right before the pandemic. Wow, time flies.
Yeah. Yep. Well, thank you so much, Derek. And I know you weren't feeling
great.
particularly well. You still killed it.
Oh.
So thank you.
Well,
Thank
thank
you
you.
for
That was-
being
Thank you
here.
guys for having me. I appreciate
Yeah,
it.
it certainly
Yeah, hope
didn't
you get
show,
some
so
rest.
get some rest. Yeah, get some
Yeah.
rest.
Thank you.
Take care, guys.
And
Sure.
great to see everyone else. If anyone needs anything, let us know. Otherwise, we will be ending the meeting. Great to see so many of you. And Saray, great that you could join us today. So glad that you could come.
Thank you.
We'll see you
All right. Thank you, everyone.